Hi everyone, welcome to our prep series on EDIC Part 1. In this video, we will tackle high-yield ICU scenarios to master the critical care concepts for the EDIC Part 1. If you want to boost your confidence before exam, this is the right place. So let's get started.
Question 1. A 63-year-old man with COPD presents with severe community-acquired pneumonia requiring intubation and vasopressor support. Blood cultures grow Streptococcus pneumoniae. He is started on ceftriaxone monotherapy. Which of the following is the best evidence-based modification of therapy? Continue ceftriaxone monotherapy as Streptococcus pneumoniae is susceptible. B. Add vancomycin to cover for MRSA. C. Add azithromycin to ceftriaxone for improved mortality benefit. Switch to piperacillin-tazobactam for broader gram-negative coverage. Add oseltamivir empirically for possible influenza co-infection. Correct answer is C. Add azithromycin to ceftriaxone for improved mortality benefit. Explanation. Combination therapy, beta-lactam plus macrolide, improves outcomes in severe community-acquired pneumonia, even when Streptococcus pneumoniae is isolated, due to immunomodulatory effects of macrolides and coverage for atypicals. Vancomycin is only needed if MRSA risk factors exist or MRSA isolated. Piperacillin-tazobactam is not required unless concern for Pseudomonas. Oseltamivir is used if influenza is confirmed or strongly suspected. Question 2. A 48-year-old man with severe asthma is admitted with hypercapnic respiratory failure. Despite optimal medical therapy, he requires intubation. On volume-controlled ventilation with a tidal volume of 6 milliliters per kilogram predicted body weight, respiratory rate 20 per minute, PEEP 5 centimeter of water, FiO2 0.6, his plateau pressure is 22 centimeter of water, but intrinsic PEEP is measured at 10 centimeter of water. Which ventilator adjustment is most appropriate? Increase tidal volume to reduce hypercapnia. B. Increase respiratory rate to improve CO2 clearance. C. Reduce respiratory rate. D. Increase external PEEP to 15 centimeter of water to counterbalance auto PEEP. Switch to pressure-controlled ventilation with higher inspiratory pressures. Correct answer is C. Reduce respiratory rate. In obstructive airway disease, dynamic hyperinflation or auto PEEP is the key problem. Management: reduce respiratory rate, decrease I/E ratio means prolong expiration, except permissive hypercapnia. Increase tidal volume worsens hyperinflation. Increase respiratory rate worsens auto PEEP. Increase PEEP can sometimes help in COPD if intrinsic PEEP causes triggering difficulty, but not to 15 centimeter of water and not as first line. Switching mode does not address expiratory time problem. Question 3. A 70-year-old woman with septic shock and ARDS is on pressure-controlled ventilation. Settings: FiO2 0.8, PEEP 12 centimeter of water, inspiratory pressure above PEEP 16 centimeter of water, respiratory rate 22 per minute. Tidal volume averages 5.5 milliliter per kg predicted body weight. Plateau pressure is 28 centimeter of water, driving pressure 16 centimeter of water. Despite FiO2 0.8, partial pressure of oxygen is 55 millimeters of mercury. Which of the following interventions is most appropriate as the next step? Increase FiO2 to 1 to achieve oxygenation target. B. Increase inspiratory pressure to achieve tidal volume of 6 milliliter per kg predicted body weight. C. Initiate prone positioning ventilation. D. Perform routine recruitment maneuver and increase PEEP to 16 centimeter of water. Add inhaled prostacyclin as rescue therapy. Correct answer is C. Initiate prone positioning ventilation. Explanation. This patient meets criteria for severe ARDS based on partial pressure of oxygen and FiO2 ratio despite optimal protective ventilation. Prone positioning is strongly evidence-based for mortality benefit. FiO2 increases risk of O2 toxicity and does not address shunt. Increasing tidal volume to 6 milliliter per kg may cause valotrauma and worsens ARDS if driving pressure is already 16. Recruitment maneuver and high PEEP may help oxygenation but has no survival benefit and higher risk of barotrauma and/or hemodynamic instability. Inhaled prostacyclin is considered a salvage option but not first line. Question 4. A 55-year-old man undergoes general anesthesia. His pre-induction arterial blood gas on room air shows pH 7.40, partial pressure of CO2 40 millimeters of mercury, partial pressure of oxygen 95 millimeters of mercury, bicarbonate 24 millimole per liter. After intubation and switching to controlled ventilation with FiO2 0.5, his partial pressure of oxygen stabilizes at 180 millimeters of mercury. The calculated alveolar arterial O2 gradient is increased. Which of the following mechanisms best explains this increased gradient under anesthesia? Reduced oxygen diffusion capacity across alveolar capillary membrane. B. Increased venous admixture from atelectasis and shunt. C. Increased oxygen consumption due to surgical stress. D. Reduced mixed venous oxygen content due to decreased cardiac output. E. Rightward shift of the oxyhemoglobin dissociation curve. Correct answer is B. Increased venous admixture from atelectasis and shunt. Explanation. Under anesthesia, loss of functional residual capacity and atelectasis are common, leading to physiological shunt and ventilation perfusion mismatch, increasing the alveolar arterial gradient. Diffusion limitation is rare in normal lungs at rest, except in conditions like pulmonary fibrosis or severe exercise. Increased oxygen consumption or low cardiac output would reduce partial pressure of O2 but not specifically increase the gradient. Oxyhemoglobin dissociation curve shift alters oxygen unloading at tissue level, not alveolar arterial gradient. Question 5. A 42-year-old man with severe pancreatitis develops partial pressure of oxygen FiO2 ratio of 90 millimeters of mercury while on mechanical ventilation, PEEP 14 centimeter of water, FiO2 0.8. His plateau pressure is 28 centimeter of water, and driving pressure is 14 centimeter of water. Which of the following strategies is most supported by evidence to improve outcomes in this patient with severe ARDS? Recruitment maneuvers with high PEEP, greater than 20 centimeter of water, and routine prone positioning. B. Neuromuscular blockade infusion for 48 hours with deep sedation. C. Inhaled nitric oxide as first-line rescue therapy. A high-frequency oscillatory ventilation to reduce lung injury. Low tidal volume ventilation, 6 milliliter per kg predicted body weight, with consideration for prone positioning. Correct answer is E. Low tidal volume ventilation, 6 milliliter per kg predicted body weight, with consideration for prone positioning. Explanation. Low tidal volume ventilation is cornerstone. Prone positioning in severe ARDS improves mortality. Neuromuscular blockade showed benefit in early studies, accuracies, but later trials, ROSE, showed no mortality benefit, so it may be considered selectively. Inhaled nitric oxide improves oxygenation transiently but not survival. High-frequency oscillatory ventilation has not improved outcomes and may increase mortality.
Dear EDIC aspirants, I believe the questions which I presented to you were useful. If you have any feedback, suggestion or comments, please write down in the comment section.